Good morning, everybody, and thank you so much for attending, and thank you, Professor Theo. I was just going to introduce Professor Theo in a brief introduction. She studied human medicine in Belgium, and then she completed her studies in Berlin. Then she received further trainings in several cities like Nuremberg, Donauwörth, and Bayreuth. And then lastly, she was in the clinic of Gynaecology, UKM in Munster, before she became the head of Sinology department in the clinic since 2008. And then in 2009, Professor Theo received the certificate of European Academy of Sinology. And in 2010, she performed an additional designing for a drug tumor therapy for breast cancer patients. And thank you so much, Professor Theo, for your time and for the lecture. And I hope it would be like very interesting to hear now from you.
Yeah, I would like to tell something about modern breast cancer therapies. And in Germany, oh, just a moment, my slides doesn't work. Okay. Yeah, what are we going to do if we want to get the diagnosis of breast cancer? After taking anamnesis, inspection, and palpation, we have to do ultrasound and mammography, and possibly sometimes it's good to do an MRI also. I don't know how it is in your country, but in Germany, the MRI is not always possible because, yeah, it's not reimbursed. That's the problem. So if we find a mass, we do minimal invasive diagnostic, and sometimes we have to do an open biopsy with open surgery. We have three possibilities to do such a biopsy: ultrasound guided, if we see the mass in the ultrasound; mammographic guided, if we only see the mass or the calcifications in the mammography. And if we don't see it in the ultrasound or in the mammography, then we can do MRI guided biopsy. We have two kinds of biopsy: the core biopsy and the vacuum assisted biopsy. So for the MRI, it's always a vacuum assisted biopsy, and the mammographic one, if we have calcifications, then we also do the vacuum biopsy. Otherwise, we do core biopsy. So you can see the different needles. The upper one here, this is a core biopsy, and this here, this is the vacuum assisted biopsy. So the volume of the specimen is bigger if you do a vacuum assisted biopsy. So sometimes if you have a very small lesion, you have to be carefully, because then with the vacuum assisted biopsy, it's possible that your mass is gone anywhere, so that you won't find it again. So you have to put a clip inside to mark the lesion, that you are sure that you will find it afterwards, after biopsy. What do we want that the pathologist determine in the specimen? After breast cancer diagnosis, we would like to have the histological type, the grading, the hormone receptors, the HER2 status, and the key I67. Oops, sorry. Sorry.
Hey, no problem. Yeah.
My phone ringing. So if we did this biopsy and the pathologists do their work, we have a post-biopsy or a preoperative conference where we are looking the clinic of the patient and all the radiology and the pathology all together to do therapy planning. do we need an operation with wire marking? Intraoperative quality assurance is very important. Or do we have the possibility to do neoadjuvant chemotherapy? So we have to decide in this biopsy conference, do we have to do the primary surgery, or is a neoadjuvant chemotherapy necessary? Sometimes tumor biology, for example, triple negative or HER2 positive patients need a neoadjuvant chemotherapy. Sometimes it's the tumor size or lymph node involvement, or because breast conserving surgery is not possible, or we have an inflammatory breast cancer. These things can help us to decide whether neoadjuvant chemotherapy is necessary. So what are we doing if we are going to do neoadjuvant therapy? We have our different subtypes: luminal A cancer, luminal B, HER2 overexpressed, and the basal-like. We have different definitions for these different subtypes. The luminal A is always hormone receptor positive, HER2 negative, and has a low Ki-67. The luminal B is like the luminal A, but with one more characteristic, like high grading or a high Ki-67 or a HER2 positive one. The HER2 overexpressed are normally HER2 overexpressed and ER or and PR negative. And the basal-like is the triple negative breast cancer. With different numbers of these patients. Mostly they are hormone receptor positive, HER2 negative, and sometimes they are HER2 positive. It's only 14%, and up to 20% are triple negative. So what does this different subtypes mean? A luminal A-like cancer normally does not need a chemotherapy, but a HER2 overexpressed or a basal-like tumor always needs chemotherapy. So why do we then do neoadjuvant chemotherapy? Sometimes it's easier for us to do the operation because we have a reduction of tumor size after neoadjuvant chemotherapy. So the chance increases to get breast conserving surgery afterwards. And this means also reduction of operative complications because maybe we don't have to do mastectomy or mastectomy with reconstruction, will have more complications. The other thing is we have an early determination of therapy sensitivity. So we can adapt the therapy procedures if we get a non-PCR, because we would like to get a pathologic complete remission through the neoadjuvant therapy, because we then know that the prognosis is better if the patients have a pathologic complete remission. And we can avoid exposition against ineffective and toxic substances. So if I see that the chemotherapy doesn't help and the tumor doesn't shrink, we can stop the chemotherapy. So we know that the pathologic complete remission is associated with better prognosis, especially in patients with triple negative and HER2 positive breast cancer. You can see it on this picture. These are the triple negative ones, and these are the HER2 positive ones. The blue lines, these are the patients who gets pathologic complete remission, and the yellow line are those patients who doesn't get a pathologic complete remission. So we can differentiate between these two groups of patients, so that we know that those patients who does not get a PCR, we have to do something more or something else. So what do we do? What is now modern in therapy of triple negative breast cancer? We have some different studies like the Keynote 522. Everyone of us knows already about immune therapy, because we have already lung cancers and other cancers where it's already established. In breast cancer, now it's also established because of this study. We know that triple negative breast cancer has a very, very high risk for building metastasis. And if triple negative breast cancer get metastasis, then the median overall survival is normally only 12 months, up to 18 months, 12 to 18 months. So we need to do more than chemotherapy. And now with this study, we put pembrolizumab, neoadjuvant and adjuvant, we put it onto the chemotherapy. So half of the patients got pembrolizumab and the other half didn't get any. They only get chemotherapy. What we can see in the study is that those patients who got immune therapy on top have a higher chance to get pathologic complete remission. You can see it here on the left side, 64.8% get a PCR and 51.2% doesn't get, get the PCR if they don't get pembrolizumab. And then we could see the EFS. And also the EFS is significantly better if the patients get immune therapy on top to the chemotherapy. So here you especially can see these upper lines are those patients who get a pathologic complete remission. So there it doesn't matter if you get immune therapy or not, because all those patients who get a pathologic complete remission has a good prognosis. But those patients who doesn't get a pathologic complete remission, if they get immune therapy on top, the risk of getting metastasis is really lower than those who doesn't get one. So 56.8% after 3 years are without any recurrence and 67.4% who get immunotherapy. So because of this data, triple negative patients should get immune therapy on top to their neoadjuvant chemotherapy. What do we do if we don't get the pathologic complete remission? Because if we know that they have a high risk to get metastasis, then those patients can get capecitabine afterwards. In this study, the CREATE-X study, you can see that all those patients who doesn't get any pathologic complete remission, but after surgery get capecitabine, they have a better disease-free survival, here 56.1% and 69.8% if they get capecitabine. And also the overall survival of the triple negative patients is 8% better than the control who doesn't get any capecitabine. So because of that, it's very important to do neoadjuvant chemotherapy to know which patients don't get the PCR so that we have the chance to do capecitabine so that the overall survival will be better. Mostly patients who have a triple negative breast cancer may have a BRCA mutation, because BRCA1 mutation means that they mostly get a triple negative breast cancer. So BRCA1 patients have a lifetime risk of 70 to 80% to get breast cancer, and a lifetime risk of 40 to 50% to get ovarian cancer. So those patients who have a BRCA1 mutation and get their cancer, in 95% of the cases, they get this triple negative one. So a very aggressive breast cancer. So, and because of that, we now have drugs, especially for patients who have a BRCA1 or 2 mutations. These patients, I will show you the study, the Olympia study. All these patients, mostly they have triple negative, but some of them also have a hormone receptor positive breast cancer. After therapy, if they don't have a PCR or they didn't get neoadjuvant chemotherapy, they get this PARP inhibitor olaparib for 1 year. And then we looked the invasive disease-free survival, and we could see that the invasive disease-free survival was better if they get a PARP inhibitor like olaparib. So also the overall survival, this is not significant, but we already can see the trend, 4% better overall survival. So that the patients who have a BRCA1 or BRCA2 mutation can adjuvant get a PARP inhibitor. In the metastatic situation, we already have olaparib already since 3 or 4 years, because also in the metastatic situation, a PARP inhibitor helps also in this group of patients with this BRCA1 or 2 mutation. So now the next question is, we have already the triple negative ones, and then we have the HER2 positive breast cancer. HER2 positive breast cancer patients also have a very high risk to get metastasis if we only get chemotherapy. So the standard therapy is chemotherapy in combination with antibodies. We have 2 antibodies, it's trastuzumab and pertuzumab. That's the standard in Germany already since a lot of years. And also in the HER2 positive breast cancer situation, it's already necessary to get this pathologic complete remission. What do we do with all those patients who does not get a pathologic complete remission? These patients get another antibody, the TDM1, because our standard is trastuzumab. And in this study, those patients who did not get this pathologic complete remission get TDM1. This means this is an antibody drug conjugate. That means that we have an antibody and a chemotherapy, which is on the antibody with a linker, fixed with a linker, so that we have a chemotherapy, especially for the HER2 positive tumor cells. So if we do this TDM1, in all those patients who did not get a pathologic complete remission, you can see here the IDFS is significantly better if the patient get this TDM1. So the standard is doing neoadjuvant chemotherapy and afterwards getting TDM1 if they doesn't get the PCR. If they have this PCR, they can get their normal antibody further on for 1 year. But sometimes we have to ask whether escalation of therapy is really necessary, or do we maybe sometimes have situations where we can do de-escalation. In HER2 positive breast cancer, patients who have only a small tumor and are node negative, so T1 cancers or cancers up to 3 centimeter tumor size, who are node negative, they get in this study, they get just half of the chemotherapy than we normally would do. They only got 12 cycles of paclitaxel in combination with trastuzumab, with the antibody. And we can see that after 7 years, still 93.3% of the patients did not get a recurrence. So this is a very safe therapy, so that in Germany, if you have a small tumor, node negative, it's okay if you do de-escalation and just do half of the chemotherapy. So we have both sides. Sometimes you have to escalation if something does not really work. And sometimes we can do de-escalation if we have very small tumors. We also sometimes ask, because in Germany, it's a little bit different than in other countries. Everyone gets their therapy, but sometimes we have old patients. And because of that, this study also looks to de-escalation. Patients who are over 70 years old who have a HER2-positive cancer, normally all of them, they need chemotherapy in combination with antibodies. But this study shows that there is a trend that sometimes it's also possible not to give the chemotherapy, but just the antibody to these patients. But in the HER2-positive breast cancer situation, we have a lot of antibodies. We also have neratinib. Neratinib is for patients who are hormone receptor positive, HER2 positive, for young patients, because if you do neratinib after 1 year therapy with trastuzumab, you can also here the invasive disease-free survival is significantly better, 4.4%. So if you have young patients with a HER2-positive breast cancer who is hormone receptor positive, then you can do the therapy with neratinib. So these patients get 2.5 years of therapy. It's a very, very long time. What do we know about surgery then? This is me, you can see. I like surgery. It's very necessary to do the operation planning in a team, in an interdisciplinary team. It's not only the surgeon who determines how I can do the surgery, but I need the pathologist, I need the radiologist, the nuclear medicine, the radiation therapist, because all of them are part of the therapy and influences my operation procedure. So in our clinic, we have this operation planning table where everyone can see this in our documents, so that everyone knows what we determined before doing the operation to this patient. So for example, wire marking, because of mammography screening, mostly, or in maybe 40–50% of all patients that we have, we don't touch a mass, we don't have a palpable mass. So wire marking is absolutely necessary. And because of that, it's very important to do the planning of this wire marking together with our radiologist. So that means, like on this picture, if we have microcalcifications, I don't know whether you can see the calcifications. No, not really. But on this mammogram, you have calcifications, and this patient has a ductal carcinoma in situ. So we have to do primary surgery. And because of that, sometimes we have a bigger area of calcifications. So that we have to do, like on this picture, 2 wires, so that in between these 2 wires, we have the calcification, so that the surgeon knows which area he has to put away. So we need a documentation. So the radiologist has to write down how he did the wire marking. Sometimes we just need one wire mark, like in this picture. We have here our invasive carcinoma, but also in the big breast, we do palpation and the mass is not palpable. So also we do a wire mark inside. So wire marking can happen ultrasound guided if you see the mass in the ultrasound. And if you doesn't see the mass in the ultrasound, you have to do it stereotactic with the mammography. You can see it in big. So for us, it's important if we did the excision of the mass or of the tumor or the calcifications, we have to orientate the specimen, because otherwise no one knows how this mass was in the patient, because we need this information for the margins afterwards. So we in our hospital, we have this kind of marking, and then we put it on this breast. Yeah, this is like a plate, and you can put the specimen on it, or here, like here in that picture. And then we put the specimen to the radiology, and the radiologist do a specimen radiography. So like this, and then we will get this picture. And if we get this picture, then we really can see where is my calcification. Here is a clip inside, because we have here an invasive carcinoma and we have calcifications. And here you can see this is a little bit eccentric. So sometimes it's necessary, if the calcifications are not with a good margin, we can do resection intraoperatively already. So because of that, the specimen radiography is very, very important. Except we can, or we have a mass that is palpable, then we don't need this radiography. But mostly, the most patients in our hospital don't have a palpable mass. Breast conserving surgery can mean a lot of kinds of operative surgery. If we have small cancers, it's not so difficult to do breast conserving surgery, but sometimes we have big masses, but sometimes German breasts are big breasts. So it's very important also to do oncoplastic surgery. Like on this picture, this patient has a tumor here in the lower quadrant. If we just do the excision, then we have the problem that the nipple will look to the side, and that's not a good cosmetic result. So sometimes if we have big breasts or big tumors, it's necessary to do a tumor adapted reduction mammoplasty, like a reduction mammoplasty. The operative procedure is just like the same, like the plastic surgeons do, but also in oncologic surgery, we also can put sometimes 5 or 7 or 10 centimeter big tumors. We can treat them with breast conserving surgery if we can do all these techniques. Or another example, a V-plastic. This is a tumor in the center of the breast. The nipple has to be, we have to do the excision of the nipple also. And then we can do this B-plastic. Here is the new areola. And we can put, this new areola into the middle of the breast so that you have this kind of surgery. This is one of these patients with a B-plastic. And afterwards, for the nipple, we can do a tattoo. A lot of our patients like having a tattoo. to do reconstruction of the nipple. Some patients still need a mastectomy. It's important sometimes to do this, but most of the patients would like to get a reconstruction. So in Germany, it's necessary, if you have an indication for a mastectomy, you have to offer the patient also a reconstruction. Mostly the reconstruction, it's possible to do it in the first operations, an immediate reconstruction. Only in a few cases, for example, in patients with inflammatory breast cancer or something like that, can't do that. But mostly, for example, a DCIS, what is very big, or a cancer with a big DCIS, yeah, reconstruction is immediately possible. What do we have for different kinds of reconstruction? On the one hand, we can do implant reconstruction, like on this picture. So we have our implant silicone filled. Normally, we put it under the musculus pectoralis, and we can do a skin sparing mastectomy. Sometimes we also can do a skin and nipple sparing mastectomy. It's dependent on the tumor itself, whether the tumor is behind the nipple or anywhere. So these are some results of reconstruction with implants. This is on both sides. This is a patient who has the implant on the left side and a reduction on the right side, so that she has a nearly symmetric result. And these two also have implants on both sides. But you have to discuss with the patients, because sometimes it's necessary to do radiation therapy. So if you do implant surgery and you do a radiation therapy afterwards, the risk of getting complications with your implant, to get a capsule fibrosis, is higher than 50%. So these patients who need radiation therapy, they would better get reconstruction with tissue and not with implants. Yeah. What can we do? We can do this deep flap. Deep flap means that you can get this fat, but then you need also patients, if they don't have fat, then we have a problem. Then sometimes we can take maybe the, how do you call it? The leg, fat of the leg. But mostly we have to put this from your belly. So the fat of your belly, you can do this excision of this fat with this vessel. And this vessel, you do microsurgery and put the vessel on a new, or on another vessel, so that you have a new blood, blood way for this fat of the belly. And then you have a very big scar here, down here, but you won't see that, because if you have if you wear trousers, then you won't see this scar anymore. And then this fat, if you need skin, you can put the skin of the belly onto the breast. If you don't need skin because you did a skin sparing mastectomy, you can put this skin away and just the fat into the breast. But these kinds of reconstruction, every patient will be offered if they get mastectomy. So mostly the patients don't get the classic mastectomy in Germany. But we also have to do axilla surgery. We know, oh, this is a slide in Germany. We do sentinel node biopsy. And yeah, until 3 years ago, maybe, if the sentinel is positive, we do have to do a lymphnodectomy of level 1 and 2. But because of the Z0011 study, we showed that those patients who have a positive sentinel node, but a clinically negative axilla, if we don't do the axilla dissection, the patients have the same overall survival and the same disease-free survival. So they doesn't have any profit to do an axilla dissection, although the sentinel is positive. We have further studies now not to do the sentinel because sometimes we ask, is it still necessary to know what axilla is doing? But a small study already showed that it's maybe better for overall survival if we don't omit the sentinel node biopsy. But we also can do different things. In this study, some of the patients, if the sentinel is positive, get an axillary dissection, and half of the patient just get radiation therapy. So what they can show is that the axillary recurrence rate, the distant metastasis-free survival, the disease-free survival, and the overall survival is just the same, whether you do surgery or you do radiotherapy. But we can see that lymphedema is a problem. So all those patients who get the axillary dissection have a higher risk to get lymphedema than the patients who get radiotherapy instead of axillary dissection. So because of these data, it is allowed not to do the axillary dissection if we have a positive sentinel, and instead doing radiation therapy. But what are we doing if we do neoadjuvant chemotherapy? We have different kinds of our procedure. The question was, can we omit axillary dissection after neoadjuvant chemotherapy? The answer is no, because we have to know what the axilla is doing. If we do sentinel node biopsy, the false negative rate is too high. And the other question is, can we omit breast surgery after neoadjuvant chemotherapy? So here are different studies who looked the histology after operation and the MRI and the mammography. So, but the problem is that not always, if the MRI and the mammography shows a complete remission, does not mean that you also histologically have a complete remission. So because of this problem, because we have a false negative rate up to 58.3% or 33.3%, it's not allowed to omit axillary and breast surgery after neoadjuvant chemotherapy. But what are we doing with the axilla? Patients who have a negative axilla before chemo, they get a sentinel node after chemo. And those patients who have a positive axilla before chemo and afterwards have a clinically negative one, you still have to do axillary dissection, because sentinel lymph node has a high false negative rate in patients after neoadjuvant chemotherapy. So, but the new kind of operative axillary surgery is the targeted axillary dissection. What does this mean? You have to do minimal invasive biopsy of the suspicious lymph node before starting the neoadjuvant chemotherapy, put a clip inside the suspicious lymph nodes, and afterwards, if after ending with the neoadjuvant chemotherapy, the axilla is negative, then you just do the excision of the clip-marked lymph node and the sentinel node. But it does not make sense if the axilla is full of lymph node metastasis, because this procedure means that in each suspicious lymph node, you have to put this clip and have to do the excision of each clip afterwards. So if you have 10 lymph node metastases, just do an axillary dissection. The study who showed that targeted axillary dissection is safe is this one. In this study, they did that what I just told before. And these are the results, 208 patients. In 115 cases, the clip was in the positive lymph node. So we have a false negative rate of 4.2%. If we just do only sentinel node biopsy after neoadjuvant chemotherapy, we have a false negative rate of 10.1%. But if you do the excision of the clip-marked lymph node and the sentinel node, the false negative rate is only 2%. So this is a safe kind of axillary surgery after neoadjuvant chemotherapy. But we have some problems because sometimes we don't find the clip-marked lymph node. And what do we do then if we don't find the clip-marked lymph node? And sometimes it's a little bit difficult because maybe it's meaningful to check the suspicious lymph node with Udine seeds or something else. And it does not make sense that what I told before, to mark 10 lymph nodes because you have 10 positive lymph nodes before, then it's better to do lymph node surgery classically like we do always. So then everything is going to the conference again. The pathologists demonstrate their results. We do the correlation between result and radiology. And we have to decide whether a reoperation is necessary. And we have to decide about adjuvant therapy, like radiation therapy, endocrine therapy, adjuvant chemotherapy, or maybe adjuvant antibody therapy. So this is now the last one. What do we do with the hormone receptor positive, HER2 negative breast cancer patients? All of them, they will get endocrine therapy for minimally 5 years up to 10 years. This is the standard in Germany. But sometimes high-risk patients with positive lymph nodes maybe need more than just the endocrine therapy or chemotherapy. So in this study, we are examining the CDK4/6 inhibitor. These are, every one of them are patients with more than 3 positive lymph nodes, or if they have 1 to 3 lymph nodes, they have a big tumor, a high grade or a high Ki-67, and they get after chemotherapy and operative surgery, they get their standard endocrine therapy in combination with abemaciclib, a CDK4/6 inhibitor. So, and what you can see is that the invasive disease-free survival is better significantly if they get abemaciclib. So this study showed that really high-risk patients profit from getting abemaciclib for 1 year on top. So you can here also see the patients with the Ki-67 bigger than 20% and the DRFS just the same. This is escalation of therapy for high-risk patient, but also in patients who are hormone receptor positive, HER2 negative, we also can do de-escalation. This study showed that those patients, if you have a hormone receptor positive patient, these patients will get 3 weeks endocrine therapy before surgery. So, and then we also do molecular genetic analysis like Oncotype DX in this study. So on the biopsy specimen, we do the Oncotype DX. Then after 3 weeks, we determine the Ki-67 a second time. So if the Ki-67 drops under 10% and they have a recurrence score up to 25, from 0 to 25, then they just get the endocrine therapy alone without chemotherapy, even if they have a nodal positive breast cancer. If recurrence score up to 25 and the Ki-67 drops under 10%, endocrine therapy alone helps. If the Ki-67 is higher, then they still get chemotherapy. So, and the data showed that these patients, although they have, some of them have a nodal positive disease or have a higher recurrence score up to 25, their invasive disease-free survival is very good. So that a lot of patients, we can omit chemotherapy, although they have positive lymph nodes. Also in hormone receptor positive breast cancer. You can see the effect in patients who are older than 50 and also who are younger than 50. There is just one exception. Patients with 3 lymph nodes, positive lymph nodes, they don't have, aren't so good as all the others. So up to 2 lymph nodes, we don't have to do chemotherapy if we do an endocrine therapy before and look for the Ki-67. So now I thank you for listening, with greetings from Munster and greetings from our operative team. Thank you so much.